Good morning. Welcome to the Department of Medicine Ground Rounds. This is the last ground round of the academic year, and we are promised to be in a beautiful auditorium at the basement of the ACV building when we return in September. But just because it's the last ground rounds is not a time to forget about the important people in history who made this day interesting. So on this day back in 1899 was the birth of Fritz Albert Lippmann. And Fritz Albert Lippmann was a German-American biochemist who won the Nobel Prize in 1953 for medicine and physiology for discovering or co-discovering coenzyme A, which when it comes together, the protein and enzyme come together, they move acetic acid to citric acid, which is a new way of transmission of energy in the cell, or at least that was thought at that time. On this day was the death just 4 years ago of Richard Darwin Keynes, who was a great-grandson of Charles Darwin, and he actually published the book, The Beagle Record, in 1979, which described the voyages of Darwin. But he was also very well known. He was a pioneer in physiology of nerve conduction. He actually was one of the first to use sodium and potassium tracers to look at how an impulse is transmitted on squib axons. So that was kind of interesting. But also, the last person I'm going to tell you about today was born in 1942, and it was Berg Sackmann. He was a German medical doctor and research scientist who in 1991 won the Nobel Prize for Physiology of Medicine because he discovered patch clamp techniques. He actually developed patch clamp techniques to evaluate voltage and electrical transfer across membranes. And he was born in 1942 at a time when A.J. Quick was describing the prothrombin time test. And he described that hemophilia, that there was that was not a problem, and yet there was the delay in clotting. And today, our speaker will tell us a lot more about this and the efforts that are terrific efforts at the university to address this issue in our community. So I introduce Dr. Don Miller, head of the Cancer Center, who's going to introduce our speaker.
It's a pleasure to introduce today's speaker for Medical Grand Rounds. Vivek Sharma grew up in India, went to medical school in Pune, and then trained first as an internist and then as a surgeon, but saw the light and decided to come to Louisville, where he did his medical residency. Was really a very, very outstanding fellow with us, and we were pleased when he joined the faculty in 2001. And Vivek has just done a beautiful job. About the time he joined the faculty, Don Fleming, who ran the Hemophilia clinic, left, and we imposed that duty on Vivek. And over the last decade, the Hemophilia clinic has just blossomed, and he's doing some very interesting clinical trials and has really become the regional expert in clotting. And I realized as I was thinking about this Grand Rounds that in the 15 years I've been here, we've not had a Grand Rounds on clotting, and it's about time. Vivek is going to talk today about blue blood and bleeding blues.
Thank you. Thanks, Dr. Roman and Dr. Miller, and thank you all for coming. This room is distributed a little bit differently from what I'm used to, so I just want to make sure if everybody can hear me well, especially at that corner there. Okay, great. So, as Dr. Miller said, we have a hemophilia treatment center here, and we have a sizable population of hemophilia patients, but I would surmise that most of you all are not going to go back after this talk today and see any patients that have hemophilia. So this is not a disease that many people are very familiar with, even though, as you will see, that things have advanced substantially just within the last century. So because it's a disease that is relatively specialized, what I'm going to endeavor to do is really give you an overview of the disease in general, just the understanding of what this disease is, and some conceptual aspects of the management of the disease. So because the topic is so broad, we're not going to delve into a lot of details about individual things, but I think we'll touch on the key aspects of all things that pertain to hemophilia. So Dr. Romans likes to put things in historical perspective, and so I'm going to start by kind of you know, putting things in perspective as to where things have been over the last several centuries as far as hemophilia is concerned. It's a rare disease, and like most rare diseases, it, for the most part, languished in obscurity for centuries. There have been mentions of it as far back as, you know, the early part of the first century AD, where Jewish rabbis actually wrote in the Talmud that if a woman has 2 children that died of bleeding after circumcision, then next time they got pregnant, they would be exempt. The child would be exempt from circumcision. Now, they had no idea what this disease was. They had no name for it. They did not describe anything else about it. But this probably was a situation of hemophilia. And then there's really nothing from that point on until sometime in the 11th century, where an Arabic physician, Albacasis, described a family or a few families where males had hemorrhagic disorders. And this probably also referred to hemophilia. Again, no name, nothing. Nobody really cared much about it. There was no publications, no significant reports about the disease. Until early 1800s, 1803, a physician from Philadelphia by the name of Otto, John Conrad Otto, described a family, again with male patients who had the disease, who had hemorrhagic disease, and he tracked their lineage. And what he found, interestingly, was that it was always happening in male members of the family, and he tracked it to a female who had settled in the Plymouth area in the 1700s. So again, didn't name the disease, but really probably described the disease quite well. And not only that, he described the inheritance pattern of the disease, which we now know to be X-linked. In other words, it's a disease that is caused by a mutation on a gene that is located on the X chromosome. And therefore, because females have 2 X chromosomes, you know, they typically are carriers. But males that have only 1 X, if they get a mutated gene, that's all they got, and that's when they express the disease. So it wasn't until 1828 where really a relatively obscure review by a physician in Zurich first used the term hemophilia. It's a really odd name if you think about it. You know, hemophilia is like the love of blood, or the people that love blood. It's really odd, but nobody had named that at all. And so it's a name that just stuck after that, and we're still using that name up to now. But then after that, you know, after his publication, things still remain, you know, relatively obscure. Nobody, hemophilia, fine, you know, so what? You know, nobody really cared about it. And again, the reason being, it's a rare disease. So, but something changed in the mid-1800s. Now, when you're talking about a rare disease, and for people to really take notice and get very interested in it, there are 2 things that usually have to happen. One is that you get a highly effective treatment for the rare disease. And that has happened recently with certain diseases, which compels us to be more aware of it, because if it's a life-threatening disease and we have a highly effective therapy, we need to know about it. But the other thing that can make a rare disease more prominent is if somebody really famous and really important gets involved. And somebody got involved with this disease in a really big way, a very high profile, very important person in that day and age in the mid-1800s. This is Queen Victoria, which everybody here knows. She was the first one in the royal family that turned out to be a carrier. She probably was a spontaneous mutation, either from a mom's side or a dad's side, or maybe herself when she was, you know, but either way, she turned out to be a carrier. And she had 9 children, 5 daughters and 4 sons. One of her sons had hemophilia, and he died of hemophilia. 2 of her daughters were carriers. And because remember, females usually are the carriers, males are the ones that have the hemophilia. And they passed the disease on not just to the British royal family, but other royal families in Europe. And this family tree, if you look at this, summarizes the people. So what you see here is, this is Queen Victoria, and everything that is shaded in green is somebody that is either a carrier. The round circles are females, the squares are males. And so you see that Queen Victoria, 2 of her daughters, Alice and Beatrice, were carriers. Leopold was born in 1853. He was a hemophiliac. So he was the 8th child. And nobody really knew that she was a carrier until Leopold was born, because the carriers really don't express anything, and they were not old enough to have had children that would express the disease. And so by the time Leopold was born, that's when they realized something was wrong, because he started bleeding, and bleeding severely. He had a pretty miserable, painful life, and he died of a intracranial hemorrhage after a minor trauma when he fell down. He was about 31 years old when that happened, but he had already had a couple of children by that time. Now, as you can see, Beatrice here, her children through that lineage, the disease went into Spanish royalty, and then also over here through Alice, it went into German royalty, Prussian royalty. And what I want to take a little bit more time, because this is another high-profile situation, is the way the disease spread to Russian royalty. And that is through the granddaughter of Queen Victoria, who was the daughter of Alice. Her name was Alexandra. Alexandra married Tsar Nicholas, who was the Tsar of Russia at the time. And they had 4 daughters, and their 5th child was a son. Unfortunately, he was a hemophiliac. Now, historians have kind of debated this back and forth, but a lot of people feel strongly that this event of Alexei, the Tsar, the next Tsar apparent, the next heir apparent, had hemophilia, had a major impact in the historical turn of events in Russia. These are real pictures. This is the Tsar Nicholas. This is Alexandra. These are their daughters here, and this right here is Alexei. And he was diagnosed with hemophilia. He had severe problems, again, with bleeding, very painful joint bleeds, which is typically what happens with hemophilia. We'll see that in just a minute. And nobody at that point in time could do anything to help him. The physicians couldn't do anything. They called other people, alternative medicine people. Nobody could do anything. But then there appeared this person who was a mystic kind of a guy over here, which many of you all might recognize. This is Grigory Rasputin. And he was the only person who somehow, and people have different theories about it, maybe he used hypnosis, maybe there were some other things, he was able to control his pain, Alexei's pain, and he actually had some reports where he could actually reduce his bleeding. So because of the fact that he was the only one that could do this, the royal family, the influence that he had on this royal family was amazing. He was able to literally direct some of the policy of the time. And it is felt that this probably is what led to the Russian Revolution, where things that were already unstable in the country at the time became even worse, because the Tsar was completely consumed, and his wife, with Alexei's hemophilia. This was a very, very devastating blow to this family, who thought that this is going to be the next Tsar, and now he's a fragile person. They're trying to hide him from public, and they come under the influence of this gentleman here, Mr. Rasputin, who probably, there are a lot of debatable things about him, but he was the only one that could help this kid. But apparently, this was used by the revolutionary Bolsheviks to gather more support for themselves. And the Tsar was completely distracted. And a lot of people feel that is what eventually led to the collapse of the empire. I think one of the things this shows is the kind of impact this disease can have on a family. And this is a royal family with, they were monarchs. They had all kinds of resources available to them. It's true that there was no treatment at the time, but the effect that it has emotionally, physically, psychologically on families that have a child with severe hemophilia is really quite severe. So, when all this was happening, all these high-profile cases in royal families, this really skyrocketed the interest and the investment in research and understanding and treatment for hemophilia. A lot of it was just because it was so visible. Some of it could have been out of sort of a motive of getting favor with royal families. There are many groups and physicians at the time that they were still monarchies. They had not, at that point, they had just started shifting to constitutional monarchies. And getting favor with royals would be great, even if it's a rare disease. So this really led to a big spike in research and investment and therapeutic attempts for patients with hemophilia. Now, what I'm going to do next is, with the understanding of what this disease has been historically, I'm going to kind of give you, in a nutshell, what we have learned over the last several decades about the disease and how it happens and what happens in the disease. So in order to understand what hemophilia is pathophysiologically, I think it's important to start with how normal hemostasis occurs, just so that everybody's on the same page. I know that coagulation is not something that a lot of people take interest in or know a lot of details about. So we just want to make sure we are all on the same page. So when you talk about normal hemostasis, there's two main components to it. Whenever there's any hemostatic challenge, you have two main components to it. One is primary hemostasis, which is an immediate response where you have basically constriction of blood vessels, which is sort of a mechanical event, almost like the application of an artery forceps. And then you have the formation of a platelet plug through elements such as von Willebrand factor, and which form sort of a glue, and the sticking of platelets, which plugs up that initial breach in the endothelium and stops the bleeding, at least initially. And this is a cartoon that sort of brings that out. And what you see here is that there's a breached subendothelium, as shown here. And when that happens, von Willebrand factor is able to bind to it through collagen and various other receptors. And that in turn opens up binding sites for a receptor called GP1B9, which many of you are familiar with, where platelets bind to the von Willebrand factor. And so as a result, you basically get a whole host of platelets lining the endothelium, which is called platelet adherence. So it's a bunch of platelets just forming a sheet on the endothelial surface. And then that is followed by more platelets binding through another receptor on top of this initial layer through a GP2B3A receptor, and that is called platelet aggregation. So now you don't just have a sheet, you have a clump of platelets. So that is great, and that is important, but that's not the only place that you can stop. You need to do something else to this, because when blood is flowing inside a blood vessel, there's a substantial shear force that is applied to it. And this plug is relatively flimsy. It's easy for it to fall apart. And unless something else is done to strengthen it, it's not going to last more than maybe 2 or 3 hours. Okay. And this is just kind of showing you that inside blood vessels, even if you form a plug, you have to deal with a lot more than just putting something on there. It has to be able to withstand the force of the blood long enough for the endothelium to heal. And that's not 2 or 3 hours. That's a few days. And so you need something more to do that. And that something more is provided by the secondary hemostatic system, which is the formation, which results in the formation of this tenacious material called fibrin, which is then able to form a meshwork around this initial clot and stabilize it so it doesn't fall apart in a few hours, but actually can last for a few days, so that the healing can take place and the patient does not bleed. Now, I'm not going to belabor this for too long, because again, this is not something we need to know details of, but I just want you to follow with me, because the coagulation cascade can sometimes look a little complex. But what I want you to focus on is the last part here, the end result. And that's what we are really interested in, is the formation of fibrin, and that resulting in a stable clot. The way fibrin forms is through the conversion of fibrinogen to fibrin by this molecule called thrombin, which again, I think most of you all are familiar with. And so the coagulation cascade is driven to make high quality and large amounts of thrombin whenever there's a need. And so this is a simplified version, but basically tissue factor and factor 7 interaction is felt to be one of the most important triggers in initiating hemostasis. Whenever there is damage to any tissue factor is released. And that in turn then, through factor 7, activates factor 10, which then causes, in combination with factor 5, of which we have a small amount present, it's just a tiny amount of activated, like a tick-over activation that is present. It's almost like, having some sort of a activated amount that can be used to pick up and take off if something triggers a higher production of the factor 10. And what that then does is that this combination of 10A and 5A, which is called the prothrombinase complex, cleaves thrombin and starts causing a positive feedback loop into this complex here, which is factor 8 and then factor 9. And this results in what we call as an amplification loop, where you get a substantial generation of thrombin, which then causes formation of a good amount of fibrin, and you get a stable clot, and the patient is able to have hemostasis until the fibrinolytic system, which obviously we're not going to get into, is able to clear it out eventually. And that's how normal hemostasis proceeds. Now, if on the other hand, this will happen if all these things function right. But if on the other hand, one of these products here is missing, and what I want to focus on today is the classical secondary hemostatic defect, which is hemophilia, and that is the deficiency of either factor 8, which is hemophilia A, or factor 9, which is hemophilia B, which is something we have learned. Actually, we just learned that in the 50s. But if one of these products is missing, once this reaction is initiated, the system tries to go into amplification, but there is nothing there for it to move forward, because this element here is, think of it like a bunch of dominoes. They're just kind of falling one after the other, but if one of the dominoes is missing, then it stops right there. And what ends up happening then is you get a very small amount of thrombin, and what you get then is really, you get some fibrin, but it's not high quality fibrin. It's flimsy, loose kind of fibrin that doesn't last very long. And that's really essentially what happens in hemophilia. So this slide really summarizes, and I think this is important to understand the concept of what happens in this disease, summarizes what we see in hemophilia. So on the left side, you see the normal situation, which I just showed you. When you have bleeding, you have a primary hemostatic response, which is constriction of blood vessels and formation of a platelet plug. And then, if everything proceeds normally, a fibrin clot is formed, and everything is fine. The patient eventually heals up, and there's no problem. Here's what happens in hemophilia. Notice that they go exactly the same way until the formation of the platelet plug. But after that, that's when things fall apart in hemophilia. Because of the absence of either factor 8 or 9, you have the formation of a plug that basically is blown off by the blood that is flowing through the vessel. It falls apart, and the bleeding restarts. And this is the crux of the problem in hemophilia. Now, there's a couple of things to understand here. One is that this helps you understand that bleeding in hemophilia is a delayed phenomena. What do I mean by that? So if somebody has hemophilia and they get injured, and especially if it's a minor injury, their bleeding is not going to manifest right away. The extent of their bleeding is going to manifest over time, usually over several hours. Somebody could get a trauma, and they could come and be evaluated in the ER, and if you look at them, they may just look like a normal person, may have a little bruise or something, but nothing else. But if you don't fix their deficiency, within a few hours, that patient could have a huge hematoma and could basically have a life or limb-threatening bleed. So it's a delayed kind of bleeding. And the other thing that is important to know about hemophilia is that the bleeding tends to be, and this is true for all secondary hemostatic defects, the bleeding tends to be in deep-seated structures, such as joints and muscles and so forth. Unlike disorders of primary hemostasis, where the platelet plug is not formed properly, where the bleeding is usually immediate, and it tends to be more superficial, like in skin and subcutaneous tissues. So with that pathophysiology in mind, let's look at some epidemiological aspects of hemophilia. I told you already that there are two types of hemophilias, type A and type B. Type A is deficiency of factor 8, type B is deficiency of factor 9. And it turns out that the factor 8 deficiency is substantially more common. About 80% of hemophiliacs are hemophilia A patients. Factor 9 deficiency was actually discovered later, almost by a very astute observation, that when they found a couple of hemophilia patients, and I don't know why they were doing this, but they were mixing their plasma, one hemophiliac and another, and they discovered that plasma of one hemophiliac fixed the abnormality in the other. And that is the first hint that there was another disease besides factor 8 deficiency. And eventually, patients like that were identified, and their blood was studied in more detail, and it was found that it was factor 9 deficiency. It's also called Christmas disease, and that is named after the first patient in whom a lot of this workup was done, Stephen Christmas, who was a patient with hemophilia B from Canada. This was all done in the 50s. So that's the frequency of the different types of hemophilia. How common is it? The estimates are that about 1 in every 5,000 male births is a hemophiliac. Now, these numbers of prevalence in the US, the 17,000 males, this is from the early 90s. The CDC has updated since then based on births and deaths and so forth. And the current estimate is more around 20,000. And as I'll show you later on, with the improvement, the continuing ongoing improvement in the lifespan of these patients, this prevalence is probably going to go up with time. And in terms of ethnic groups, it occurs in just about any ethnic group anywhere in the world. It's basically a global disease. So I think we've kind of so far gotten an idea about the pathophysiology, the epidemiology of the disease. Let's go ahead and delve into the clinical part and see how we make a diagnosis of patients with hemophilia. As I said, it's an X-linked disease, so you will, in most patients, probably 70% of the patients, you will get a family history where you will find male relatives are affected, females are not, and that's typically a big tip-off. You will have a clear-cut history in those kind of patients. But the caveat is that it may not be forthcoming in every patient. So if you see somebody that looks like hemophilia, but they don't have a family history, that's not entirely impossible, because up to a third of patients with hemophilia have no family history probably because of new mutations. Queen Victoria was such an example. Obviously, the classical symptoms of hemophilia is really what tips off most of the investigations, unless somebody has a family history, in which case the males will be tested at the time of birth. And finally, once the disease is suspected based on these criteria, the final diagnosis is established by doing actual individual factor 8 and factor 9 assays, which, as you can imagine, is absolutely necessary for treatment, because the treatment of one requires a specific factor, and you cannot treat factor 8 deficiency with anything other than factor 8. So you have to know the factor levels. The other important thing that the factor levels tell us is the severity of hemophilia. Now, this is another important concept that I just want to take a minute and tell you all about, because sometimes there's some misunderstanding about this. So severity of hemophilia is described based on the levels of the factor, and this is true for both factor 8 or 9. And by the way, clinically, they look identical. They bleed the same, everything looks identical. You have to know the factor levels to know which kind it is. Severe hemophilia is when factor levels 8 or 9 are less than 1%. Moderate is when it's 1 to 5%. Mild is when it's greater than 5%, usually 5 to 25%. Now, a couple of things, and I like to tell this to our residents and interns and fellows all the time, is that when you look at this classification, don't even consider it when somebody comes to the ER after trauma or if somebody's going to surgery. This classification is irrelevant for patients like that. Somebody that has mild hemophilia, has 20, maybe 10, 20% factor level, they're going to bleed to death if they're not adequately replaced when they come with a major trauma or have a major hemostatic challenge. So this classification does not apply to that. What this classification applies to is the risk of spontaneous bleeding. So what is spontaneous bleeding? It's anything where a patient starts having a bleed, be it in their joints or in their muscles, almost on a spontaneous basis, where they could be just sitting in a chair watching TV and they get up and the next thing you know, they've got a joint that is gradually swelling. And that's a spontaneous bleed. So in severe hemophiliacs, the rate of spontaneous bleeds is almost 4 to 6 a month on an average. In moderate hemophiliacs, it's 10 to 12 a year, okay? And in mild hemophiliacs, it doesn't happen. There is no spontaneous bleeding in mild hemophiliacs. And so they usually only bleed when they have trauma or they need surgery. So it's important to know this for that reason, so that we can plan their long-term management. But I think there's another important concept here that is interesting to understand, and we'll allude to that when we get to management, and that is, look how little change is needed in the expression of factor to change the phenotype. You just have to go from 1% to 2%, and you go from severe to moderate, and you just get up to 5-6%, you're in a mild phenotype. So this is an ideal scenario where you could design prophylactic strategies, and you could probably, and it has in fact been an ideal target for gene therapy. We'll touch on that in a little bit later on, but I just want you to notice that it doesn't take much to change the phenotype from severe to moderate to mild. Just a slight change in the factor does that. Okay, let's look at the actual clinical manifestations of hemophilia. I've already told you a lot of this, and I think you all know about this, but The main thing, the biggest complication that patients with hemophilia deal with is joint bleeds. And this is really the bane of their existence. They have, like I said, severe hemophiliacs can have as many as 1 or 2 bleeds a week. And what that does then is that when the blood comes into the joints, it starts causing an inflammatory response, usually a synovitis, which is almost reminiscent of what we see in rheumatoid arthritis, like a destructive pannus that is just eating away at the joints. The most common joints that are involved are in this order right here: knees, elbows, ankles. Notice they are mostly hinge joints. They are the ones that are affected the most. The ball and socket joints can also be involved, but much less commonly. Now, people have done a lot of research, and I don't have time to get into the details, but I'm going to summarize of all the stuff that goes on in these joints. And this was actually a lot of labs that have published their work on what happens inside these joints when the blood goes in there. You get a release of all kinds of inflammatory cytokines. You get expression of c-Myc, overexpression of c-Myc. You get increased expression of a tumor suppressor p53 binding protein. So this protein binds p53 and downregulates it, which again is a proliferative stimulus. You get increased expression of vascular angiogenic growth factors. So try to draw more blood vessels, more inflammation into the area. And then you get cartilage destructive processes going on. So it's just a whole host of molecular reactions that are triggered that then result in these horrible consequences for these patients. This cartoon kind of walks you through what happens with most of these patients. What you see here is an early bleed, which many hemophiliacs actually feel. And I'll allude to that in a minute when we get to the management. And that is that it's sort of a bubbling feeling. They call it the hemophilic aura. Just like how patients that have seizures have an aura that they're about to have a seizure. Hemophiliacs can tell when a small bleed is starting. But if this is not checked, if you don't replace the patient quickly and adequately, this then progresses to the next stage where you start getting a lot of swelling and pain, and this is a pretty miserable thing. And imagine back in the days of Leopold and Alexei, there was nothing to treat these patients. All you could do is, pat them on the back, sing them a lullaby, and that's pretty much it. And this was pretty bad. This is the reason why it's such a miserable disease back then. Average lifespan was 8 to 10 years. And then this eventually progresses to a more progressive destructive joint disease with synovitis, and that ends up in basically a completely destroyed joint with, obviously, when the joint is painful, they don't move their joints, the muscles get wasted, gets frozen, and you have teenagers and people in their early 20s with joints that look like this. And this is actually a good-looking patient. There are ones that look even more mangled and twisted than this one. Fortunately, this has become now in the recent generation a thing of the past, but this was a common thing with hemophilia, even when we had some of the more newer treatments. So joint disease is really the biggest problem these patients face. But besides that, as you can imagine, it's a hemorrhagic disease. They can have bleeding in other locations, and I want to mention a couple of other important ones. One is intramuscular bleeds, which can happen in a lot of locations and can actually turn limb-threatening very quickly if they are not addressed. They can cause compartment syndrome. And finally, CNS bleeds are potentially life-threatening in these patients as well. As you can imagine, back, not surprisingly, and before we had the current factor replacement products, the mortality rate was extremely high in these patients, about 70%. I'm amazed it's not higher than that, but it was about 70%, and it was about 30% cause of overall mortality in hemophilia patients. Okay, it was CNS bleeds. The mortality is still 20% in people that have CNS bleeds now, but the good news is that the frequency is substantially lower, and as a cause of overall mortality in hemophilia, it's less than 1%. Okay, but it is a major issue because once patients have it, even if they survive, they're at high risk of developing chronic neurological sequelae, especially in the pediatric age group. Seizures, psychomotor retardation, poor performance in school, and stuff like that. And they require very active intervention by a multidisciplinary team to prevent some of these problems. So that's, I think that kind of should give you at least a picture of what this disease is, what the spectrum of consequences are. I'm going to now go into some principles of management of this disease. But before I get into that, I think there's a couple of important points to be aware of from the historical context about the management of this disease. And we'll look at that, and then we'll jump into the actual practical management. So historically, these patients were treated pretty much with, like as I said, lullabies and just some herbs and things like that until the 40s, at which point plasma became available, and they started using plasma, which was not a big help either, because you can imagine how much plasma you're going to have to give somebody to get a factor of 8 level that is 0% to even a decent level of 30, 40, 50%. So they used to usually have to be admitted to the hospitals, spend several days in the hospital, get large amounts of huge volumes of plasma, and even then, imagine somebody who's bleeding and it takes 2 days to fix their problem. Imagine what the status of that joint is going to be by the time you're done. You probably keep them from dying, but you're not going to stop the disability and the ongoing joint destruction. A lot of that started changing, and I'm going to pick up over there when cryoprecipitate was discovered by Dr. Judith Graham Poole in 1964. She was working at Stanford for a company called Cutter, who I don't think that name exists anymore. It was purchased by Bayer later on. But they were trying to develop factor VIII concentrate, because factor VIII had been discovered by then, and they knew that hemophiliacs can benefit from it. So they were trying to extract factor VIII, and what she was doing is she had developed an assay while she was at the East Coast, and she was working for Cutter scientists in Stanford to assay the factor VIII in their pooled plasma. They used to collect a lot of plasma and try to extract factor VIII. And the way they would do it is, because factor VIII is fragile, they would freeze it, and then they would gradually thaw it, and then she would start assaying the factor VIII. And what she found was that as you thaw it, and if you took the initial factor VIII, the supernatant, there was hardly any factor VIII in there. It was very low. And so the next step she did was then she separated that supernatant, and she took the remaining frozen part, and then she took it separately and thawed that again and measured factor VIII in that, and she found that factor VIII levels were very high in that. I mean, they were all concentrated in this what we would call as a last to thaw component. So this part that thaws early seems to have less factor VIII, von Willebrand, fibrinogen, but the part that thaws later seems to have a concentration of these factors. And this simple observation really revolutionized the care of hemophilia patients. Now they could collect this. The blood banks could collect it. They could store it in small quantities. Patients were actually able to learn how to infuse it at home or even in outpatient clinics at a relatively rapid pace. So it changed a lot of things that were going on in hemophilia back then. And during the 60s, the companies finally kind of mastered the art of concentrating these factors. And you started getting mass-produced factor concentrates, where they were able to pull out the factor from a huge amount of donated plasma. And on the right-hand side, you see these big, huge vats. This is basically, you can imagine how much plasma is going to be in this. Probably plasma from thousands, maybe even hundreds of thousands of donors pooled together in these huge vats, and then they would make a concentrate. And this was great. This was like an amazing breakthrough for hemophilia patients. Not only was this an effective treatment for their disease, and it controlled their disease really well, because they could now take a small vial, they could inject themselves with it, and they could do it at home, but it also represented independence from emergency rooms and hospitals. And the whole community started gearing toward home infusions, and children started learning how to start their own IVs, and it was great. You know, the early 70s were a wonderful time for hemophilia patients. Their quality of life was improving. They were getting more independent. But while all this was happening, what we realized later on is that while this was a wonderful time for the hemophiliacs, this was also a prelude to one of the biggest disasters we have seen in the history of blood banking. So I'm going to take a pause here. Does everyone know what this is? This is a canary in a mine, exactly. For those that don't know, or that may not have heard, that canaries are birds that used to be used up actually until the mid-80s, where coal miners who used to go deep in the mines and were exposed to toxic gases, particularly carbon monoxide, which is, you can't smell it, you can't see it, and yet it can be deadly, took canaries with them because they are highly sensitive to even small amounts of carbon monoxide. And if a canary became distressed or basically keeled over in their cage, the miner had to turn around and head back. So canaries were sort of an early warning system. If you're wondering why am I talking about this right now, actually, I have not digressed. I wish I had, but I have not. Hemophiliacs have been referred to as the canaries of the blood banking system. And the reason is that in the 70s, 80s, and partly in the 90s, these patients got infected with the viruses that nobody knew about, that the blood bank was not regulating back then. The biggest ones being HIV, which nobody had heard of until the mid-80s. That's when they even found out what the virus was. And hepatitis C, which used to be called non-A, non-B. And so because nobody knew what they were, they couldn't be tested for, the people that were preparing these concentrates, and by the way, notice the size of these things, they were not treating them with any kind of viral inactivation processes. No heat treatment, no solvent detergent, nothing. Okay. So in effect, you have these two wild viruses that were spreading throughout the community, at least in a substantial part of the donor community, that was then going into these vats, which had contributions from literally thousands upon thousands of donors. And a hemophiliac would pull up one vial with about 100,000 donors contributing to it, and he would inject it several times a month. So no wonder they became the canaries for the blood supply system. 90% of severe hemophiliacs, 50% overall, but 90% of the severes, because they use more factor, became infected with HIV. And 90% of the total population, including mild, moderate, severe, became infected with hepatitis C. Most of them died with the HIV group in the 90s. That's when they started dying. About 65%, it became the leading cause of death in hemophilia. This was really a sad chapter in the treatment of hemophilia, because here we have improved their therapeutic efficacy, but they had this iatrogenic consequence, which became the leading cause of death for these patients. A high-profile name that some of you all may remember is Ryan White, who was a hemophiliac, died at the age of 19 of age-related complication, and the Ryan White Act is named after him. So that was a very dark chapter, but things started looking up for hemophiliacs after that. And here you see what happened in the 90s. The factor 8 and 9 genes were cloned in the 80s, and when you clone a gene, what that means is you can put it inside a vector. If you can put it inside a vector, you can make a recombinant protein. And that's what happened. And these recombinant proteins were developed, studied in clinical trials, and then finally got approved and were available for use in the mid-90s for both factor 8 and factor 9. And this really was a big sigh of relief for this community. And so now, at the present time, the most common way of treating patients with hemophilia, especially in the developed countries, certainly in the US, is the one I'm showing you on the right-hand side, which is the recombinant products. Now, by the way, since then, the blood banks woke up and they have made a huge amount of changes, and it really changed the way blood banking happens. If any of you have tried to donate blood, you probably feel like you're applying to the NSA or something. They'll ask you every question conceivable. They will test you with all kinds of viral tests, nucleic acid tests, and so on. So since the 90s, even plasma products have not yet been shown to be associated with a virally transmitted infection, just because the donor screening has gotten so much better, plus the viral inactivation steps that they've added, the heat inactivation, solvent detergent, and all that, have also become a lot better. But this patient population, because they were hit so hard with this, they became paranoid. And that's a really simple way to put it. And they lobbied very heavily with the scientific community as well as with Washington to try to push manufacturers to develop more and more pure products. And we've gone through 3 generations of recombinant products. So let me just tell you what I'm not going to show you the individual names. We don't have time for that. But basically what this is that you have mammalian cells, which is Chinese hamster ovary cells, and you put the factor VIII with a vector that can express it. You grow it in a culture, which is usually fetal calf serum. And when you express a lot of factor VIII, you run the cells through a column, and you pull out the factor VIII, and you have a pure form of factor VIII. That's simply the process. Here, as you can imagine, all human products are out, except you have a fetal calf serum here. Now, the one thing is that when you get pure factor VIII, it has to be reconstituted and stabilized in something. And the first generation products were stabilized in human albumin, which has never been shown to transmit, never, even before in the 70s, never been shown to transmit infection, because the way they separate out the fraction, the albumin fraction, which is the fifth fraction in Cohen's fractions. But in spite of that, this patient population was very nervous. They felt like if there was another unknown virus floating around in the community, they're going to get hit again. So they lobbied heavily to try to get this moved. And so the second generation products basically replaced albumin with sucrose, okay, synthetic. So, there's no human product at all. And finally, the third generation products replaced the medium, which is fetal calf serum, with plant-derived proteins to grow the cells. So that's the third generation products, which is what is used in really the majority of patients with hemophilia in the country. The products are usually easy to use. They are, relatively safe. They don't have too many side effects. Sometimes you might have a local reaction. The main challenge here is they're IV. So patients have to learn how to infuse themselves. Most severe patients, because they have to do it so often, learn to do it themselves. In fact, if you go to a hemophilia summer camp, they actually have sessions where they call in these kids and give them prizes for starting IVs on themselves. And it really is an independence thing for them. Many of the milds, because they don't need it very much, and some of the moderates don't learn it, but most of the severes know how to start IVs on themselves. So this is the product that we have now. So this is where we have come. So we've seen, I think you all have hopefully an understanding now of hemophilia as a disease, the pathophysiology, the clinical manifestations, and the tool that we have for managing it. In the remaining few minutes, I'm just going to show you some practical aspects of how we apply these tools in the real life setting in managing these patients. So this is something I like to go over with all of our residents and fellows as well, and some of this is very common sense. First thing you don't want to do, these patients have enough problems already. We don't want to increase them by doing some bad stuff to them. And this might sound intuitive, but you'll be surprised how many times this has actually happened. When patients with hemophilia have been given things that should not be given, like aspirin, Motrin, for pain. They have joint pain, many of them, especially the older patients. Intramuscular injections. Giving an intramuscular injection to a coagulopathic patient is not a good idea. Another important thing I'd like to tell people, residents and fellows especially, and even ER residents, is that if you see a hemophilia patient, listen to what they're telling you. Because we've had a situation where a patient with hemophilia came in saying that they were having a bleed in their thigh, and the ER doctor measured everything and said, I don't see any bruising, I don't see any change in the diameter of your thigh. Why don't you just go back and just call your doctor, in the morning, just call your hemophilia doctor. The patient went back and got admitted a few hours later with a swollen thigh, compartment syndrome, spent 3 months in the hospital, probably $1 million worth of factor, almost lost his leg. Almost, fortunately he did not. But this is an extreme example, but not listening to what a hemophilia patient is telling you can be bad. When in doubt, just give them their factor. That's what they need. Once you give them their factor, they are usually okay. You can proceed with other kind of workups. This is an important concept in hemophilia. And this is the same thing communicated here, and this is like an educational thing that is used by some societies for educating our surgical colleagues that if you got a hemophilia patient and if you need to do something, please give them their factor before you do anything, even if it looks like a minor procedure such as an intramuscular injection. Preferably you want to avoid intramuscular injections altogether in these patients if you can. As far as joint bleeds, which is the most common issue, obviously factor replacement is the most important thing there, but we do additional things. RICE stands for rest, ice, compression, and elevation, which all hemophiliacs know. They're all taught that from when they're young. And then they're given additional adjunctive treatments such as physical therapy and so on. There are other things we do which I don't have time to get into, such as anti-inflammatory medications. We sometimes give people with very swollen joints a short course of steroids to reduce the inflammation. We give them, they might actually, and sometimes if it's a very engorged joint, they actually might be helped by a joint aspiration to decompress that and remove the excess blood. So those are some of the things that are used sometimes. But in general, as long as these simple principles, importantly, give the factor when in doubt, give the factor, get their levels up to close to 100% when possible. But having said that, there are scenarios, these patients are going to face on a regular basis because it's a chronic disease. And I want to point out a couple of important concepts regarding chronic management of these patients. And that is the way we give them factor is two different strategies. One is an on-demand treatment, which simply means that patients are treated when they have a bleed. If they have a joint bleed, a muscle bleed, they're educated, they're told to immediately start an IV and infuse themselves, not to wait. That is good, but what has been found is that once a joint bleed starts, even if you treat it early, you're going to start getting initiation of joint damage. And once joint damage starts, it starts becoming a sort of a vicious cycle. And so this concept of prophylaxis, which again, I will remind you of what I told you earlier, that only a small change in the factor level can change the phenotype of these patients. So that concept was used originally starting in Sweden by Dr. Nissen, that showed that if you give people enough factor, usually for factor 8 patients, it's twice a week, and for factor 9, 3 times a week. For factor 9, it's twice a week. That if you can keep them at a trough that is above 1%, you dramatically change their joint outcomes. And so that became almost universally applied in Sweden and many parts of Europe. It has become more so now in the US. There's even a randomized trial, which I don't have time to get into. The references here. It's Dr. Marilyn Manco-Johnson from University of Colorado who led the study, rather. It was published in the New England Journal a few years ago now, which was the first randomized trial looking at aggressive on-demand, which is not typically what happens in real world, but they actually looked at aggressive on-demand versus prophylaxis, and they showed a major benefit, about a 40% improvement in the joint status measured by joint scores and MRIs in these young boys, over a 5-year period. So even in the short term, there's a major benefit. So as a result of that, most pediatric patients now that are severe hemophiliacs are on prophylaxis. And it's catching on a little bit more in adults, but it's not as much because adults mostly have already had the damage they're going to have. But as we get some of the pediatric patients transition to adulthood, many of them are able to continue prophylaxis. So before I close, I want to just kind of mention one thing that I said in the beginning, and that is that with all the advances that we have made, and we have come a long way, by the way, from the days of Leopold and Alexei in the care of hemophiliacs. This is really like a night and day difference in their treatment. And one of the things that has made the difference is this hemophilia treatment centers, with federally funded centers all over the country. We have one here at our university, which provides multidisciplinary care to these hemophilia patients. And you can see the different specialties that are here. And as you can imagine, I think I don't have to explain to you why we need all these specialists in this population, because they do have a fairly wide-ranging group of problems. So we have come a long way, and I think this is a great time for hemophilia. But can we get better? Well, I think the answer is we can always get better. But here's some things I'll leave you with. There's some things that are currently some of the top priorities in the world of hemophilia. And that is that even though prophylaxis is great and it prevents joint damage, a big problem with prophylaxis is adherence or compliance. Hemophilia patients don't like to use the word compliance. I found that out, that over many meetings, they actually have changed the word to adherence. They find the word compliance a little, I don't know, offensive maybe. But the patients, especially when they get older, when they go to college, when they start working, it's difficult to keep them doing their prophylaxis on a regular basis. So getting more efficient ways to do prophylaxis, maybe longer acting products, and they are coming. There's one for factor 9 called Alprolix that just got approved just like a month ago or so, which has cut down the infusion. Instead of doing twice a week, you can do once a week. So it's not a huge leap forward, but it's at least a step in the right direction. There may be ways to improve the way the factor is delivered. Maybe you can find ways to develop a pump to infuse it more efficiently, so you use less factor. The factor is quite expensive, by the way, and yet get a good delivery of the drug and improve quality of life. And that's something that we might actually be looking at here at our institution. Gene therapy I alluded to earlier on. Even though hemophilia is the ideal target for gene therapy, it really never panned out for most patients until this first this is the first time that there's a study which was originally published in the New England Journal about 3 years ago, looking at factor IX through this unique vector, adenovirus-associated vector with serotype 8, that has resulted in decent amounts of expression, was updated at ASH 2013, where they still showed about 2 to 3% expression. So this has now been taken up by Baxter Bioscience, and they're running the trial on that. Hopefully we'll see something along those lines. Factor VIII, still far away. It's a huge gene, much bigger gene, much more challenging to do gene therapy with that. And finally, this is something that is important really for us. Our pediatric colleagues obviously don't deal with this, but for us in the adult hemophilia world, we are increasingly dealing with issues of patients getting older. Their lifespan is now, at this point, projected to be just the same as the general population. And so we are increasingly seeing diseases of older patients. The ones that are the hardest to deal with are cardiovascular diseases for obvious reasons. You know, you treat most of these diseases with anticoagulant therapies, antiplatelet therapies, and that can be a huge problem in these patients. Not many guidelines, not much data, but a lot of people are working on it. The CDC has got a study of about 200 patients that they are going to look at to try to define some guidelines on how to deal with these patients. So I hope that this has given you all, an overview of what this disease is. And really, when you understand hemophilia, you really understand coagulation and especially secondary hemostatic defects. So I'm going to stop with that. I know we are right on time here, so I'll stop and see if there's any questions.
So I'm actually happy that Dr. Sharma presented today. This was an outstanding presentation. I just gave on Tuesday a presentation on presentation skills to the new interns. And if some of you are here, you would notice that he used many of those rules that I mentioned today. He gave you a patient, just so happened to be a royal patient, but gave you historical perspective. He started by talking rather than smashing you with a bunch of slides initially. He stuck to the rule of threes on slides. He used pauses. This was outstanding. Thank you so much.
Thank you.
So, you even got a second applause. Okay? So, tell me about what's going on in Louisville. How many hemophilias do we have here? What are you doing?
Yeah. So in our adult, so we have an adult population and a pediatric population, which is at COSAIR. In the adult population, we have about 120 hemophilia patients. About 80 of those are severe, and we have a comprehensive team. One of the most important members is right here, Patricia Ashby. She's there. She's our nurse coordinator. That's all she does. And we have clinics for these patients, both locally as well as in outreach locations. And we've got clinical trials that are going on, including clinical trials with long-acting factor product. We've also looked at some studies with some of the modified molecules that are being used, but they're kind of genetically engineering it to make it more efficacious. So we got those clinical trials. And we got a lot of these educational programs that we do, especially Patricia, our nurse coordinator here, does a lot of those for patient education and, excuse me, and just coordinating with our pediatric colleagues in COSAIR, who have, I think, about 70 or 80 patients with hemophilia, to try to develop a joint program. And what we are actively working on now is to develop our 340B, which I think you're probably familiar with since you've been involved in some of the discussions, where this is a federally funded program where the idea is, and this has been specially lobbied by the hemophilia population, is that we get a 340B status for our center, which allows us to then invest a lot more in patient-directed programs and even get more staff, like dedicated physical therapists, social workers, which we now borrow from other locations. So those are some of the activities that are going on with the center.
Any other questions?
Yeah. So that's
repeat the question?
Okay. So the question is, how often do these patients develop antibodies to the products they're getting? Because they're protein products. It's a great question. I didn't have time to get into it because it's an entire topic on itself, is inhibitors in hemophilia. It happens a lot more often in factor VIII patients because factor VIII is a much larger molecule. So just to give you an idea, the incidence is about 25% for factor VIII, about 5% for factor IX. But the majority of it is in the pediatric age groups. By the time these patients come to the adult setting, the prevalence of the inhibitors is much, much lower because our pediatric colleagues, they're the ones that deal with this usually. They have got some well-defined immune tolerance induction protocols where they expose them to large amounts of factor, and there's a high success rate, about 80% plus success rate on tolerizing those patients. So yes, it is a problem. When we do have the occasional patient, we actually really, in our 120 patients, we have one right now. When we do have an occasional patient, it is a challenge to manage. And the way we manage it, which again, we didn't have time to get into, is we use bypassing products, which simply bypass factor 8 and 9. And what that is you feed directly into the common pathway. So you have two products that are approved. One is recombinant factor 7. If you give a high dose of recombinant factor 7, supraphysiologic, it directly generates thrombin on the platelet surface, so it achieves hemostasis. And the other one is a product called FIBA, which is actually an acronym. It stands for Factor 8 Inhibitor Bypassing Activity. It's just a bunch of activated thrombin that is thrown into the plasma. So you just directly supply the thrombin. So those bypassing products are used to treat the occasional patient that we get in the adult setting. But fortunately, it's not very common in adult patients.
Last question.
Yeah.
I was just wondering if the difference in the mild, moderate, severe, is that a reflection of incomplete? For example, if you had a father who had severe disease,
Right.
passed the gene to his son.
Yes. Yes. Good question.
Oh, I'm sorry. No, okay.
Were you here?
Yeah. No, it's a good question, and it's true. I mean, the gene remains the same, and the severity depends on the type of mutation. There have been several thousand mutations that have been described for both hemophilia A and B. There are some that are a lot more common. For example, the inversion of the intron 22 is the most common for severe hemophilia. It's about 50% of them have that mutation. But the type of mutation is what defines the severity. But once a family has a certain mutation and the severity level stays pretty much the same throughout the generations. In fact, we now recently found out what the gene was in the Romanovs, in the Russian family. It was a hemophilia B gene. It was a deletion. It was basically a point mutation that led to RNA splicing defect, which causes a curtailed molecule of factor 9. So, but the severity is determined by the type of mutation.
Okay. Is the disease not frequent enough to do pre-birth screening or birth screening?
Yeah. The birth rate is about 1 in 5,000, but at this point, it is available. Pre-birth screening is available, but a lot of people have kind of shifted away from that because what they've found is, and they've found this in many surveys, is that many women, now that there's so much available for treating these diseases, they don't want to terminate the pregnancy if it's a hemophiliac. And knowing whether it's a hemophiliac does not appear to change a lot what you do with labor anyway. If it's a male infant, the only thing you don't want to do is apply forceps or vacuum. If you're not going to apply that, normal delivery is fine. If you're going to have to apply that, then you take him to C-section. So because of that, some people still do it, but because there's some risk involved in prenatal testing, small risk of pregnancy loss, etc., it's a lot less popular, but it's available.
I was more worried about early treatment and prevention of bleeding problems.
Oh, like in infants?
Yeah, so that before you get the first joint.
Yeah.
In the ER.
Yeah, that's a great question. So we don't have universal screening like we have for sickle cell. It's only done for people that either show some bleeding or that have a family history. But even if a patient has a family history and even if they are known to be hemophiliac, they actually recommend waiting till they have their first bleed many times to start prophylaxis. A couple of reasons. One is many families, especially if it's a new diagnosis, they have a hard time dealing with giving injection to a little baby when they don't know why they're doing it because the baby looks good. And the second thing is that the rate of inhibitor development, which as I just said is a much bigger problem in pediatrics than it is in adults, seems to be especially high if they're exposed to the factor in the first year. So if you can delay the onset of prophylaxis beyond the first year, then that's what's recommended. But if somebody starts bleeding a lot, then you don't have a choice. But in general, that's the reason why they tend to wait till they have their first little bleed and then immediately they start on prophylaxis.
Well, thank you, Dr. Sharma. I know that people are, you can applaud, that's fine.
Thank you.
I know you're sad that you won't be here at 8 o'clock every Thursday until September. I'll leave you with the words of Shel Silverstein, because I read his books to my children. He was the author of The Giving Tree. But he basically said there are no happy endings. Endings are the saddest part. So give me a happy middle and a very happy start. So this is the middle of the year. You gave us a happy middle ground rounds, and hopefully we'll give you a very, very good start in September. Thank you.
Thanks.
That was outstanding.
Thank you.
Thank you.
Thank you.
That was very good.